Hello, and welcome to HeartSense's The Pulse, where we focus on conversations in cardiovascular care. Today, we are going to discuss the obesity epidemic and the effects on our heart health with our co-founder, Dr. Antoine Keller of HeartSense, and our special guest for today, Dr. Rani Whitfield, primary care physician with an interest in cardiovascular disease. Dr. Keller and Dr. Whitfield, welcome and thank you so much for joining me today.
Thank you, Sabrina, and I'm very proud of my man, Dr. Whitfield. So I know he's going to drop some serious obesity knowledge on us today, and I can't wait. I got all kinds of questions for him. You know how I freelance on the questions sometimes. So.
Yes.
I'm nervous now. I'm nervous now.
No need to be nervous. And you are actually an expert on the pulse, Dr. Whitfield, because you've been featured on an episode before. So we're welcome to have you back and so excited.
Thank you. I appreciate it. It's great. Great platform. I love it.
Great. Thank you. Well, let's get started with those questions.
Okay.
So, first question is, well, I guess first off, let's start off with the whole fact that when you think about obesity, the epidemic, especially with the US, you kind of think about, oh, well, the solution is eating healthier, exercising more. But we really wanted to go beyond that today, that conversation, and focus more about why is it important for someone to think about obesity and cardiovascular care? And then furthermore, how does that really tie into those food insecurities that you find in those food deserts? So that's going to be the main focus for today.
So just to break it down a little bit more, I would like for you to talk about how diet can impact your cardiovascular health, specifically related to obesity and the kinds of things that you eat. And then talk a little bit about diabetes and pre-diabetes, because everybody has questions about diabetes and how it relates to obesity. And, you know, I have a lot of patients who come to my office and they say, well, you know, there's not very much I can do about it, doc, because diabetes runs in my family. And so how do you respond to that statement from someone who's already given up before they've even started with their diet and obesity journey?
You know what, doctor, the interesting thing you said that is that some of my folks come in and say there's no family history of diabetes in my family. So I say sometimes family history starts with you, or maybe you just don't know enough about it, about your family history. So I've been charged as a physician in my family when we have our family reunions to pick a topic. And typically I talk about one of three things: hypertension, diabetes, stroke / heart disease. And so those are the top killers in our country. They are all preventable and are treatable depending on how you get to the doctor and if you see your doctor on a regular basis. And then, of course, you have to incorporate diabetes in that conversation. All of those, unfortunately, are risk factors for, you know, heart disease and stroke. And then you have obesity as one of the most preventable causes of heart disease and stroke. Unfortunately, though, many people think that obesity is someone's fault. You know, like, oh, they're just lazy, they're just not exercising. And so that's where you get into, Sabrina mentioned earlier, we talked about food deserts. So I'll kind of step back because I know we're going to get into those things. It's just, it's such a broad topic in so many areas where we can go with this. But as you know, obesity is a leading cause of cardiovascular disease, mortality, and morbidity. And we define it as an accumulation of fat. The World Health Organization defines it as an accumulation of fat or abnormal excessive fat accumulation that presents a risk to health. The quickest way to measure it in my office, we do something called the BMI, but there's much better ways to assess that, but we can't always afford to do them, and they're not always timely. But when it ties into diabetes is definitely a risk factor for heart disease and stroke, and diabetes is also a risk factor, or vice versa, for obesity. And when I'm
let's start with some facts. I'm sorry to interrupt you, but let's start with some facts. So you said BMI, basic metabolic index, or what does BMI stand for?
So the basic metabolic index, or the body metabolic index, is a measure. Basically, we're taking our height in inches or centimeters or kilograms of height, and you divide that by your weight, and so that can give you this number. And if your BMI is greater than 30,
that means you're obese.
If your BMI
So
is greater
that's
than 25, you're
fact
overweight.
number one.
Right.
BMI,
Right.
you got to be less than 30. We got to put that in
Actually, no,
people's
Doc, you
heads
want to
so
be
that they can know something to
you
do.
want to be less than
I'm sorry.
25. So if your BMI is greater than
So
25, you're overweight. If your BMI is greater than 30, you're considered obese. But a lot of things play into that. Bone density can increase your weight, so that can increase your BMI. So you could have a very muscular guy who has a low body fat, and actually
yeah.
body fat percentage is a better measure of cardiovascular health than BMI. But again,
So athletic people sometimes are told that they have high BMI or their BMI is more than 30, but is there an allowance that's made for people who, you know, like me, who have these guns, and I see you on the internet working out every
I
day,
figure what you were
and
doing with that. Sorry.
I just want to know if, you know, if somebody said I got a BMI of 30, but I'm not really obese, am I? Are there exceptions?
yeah, there are exceptions. So again, we have these broad definitions of BMI and body fats, but you have to treat that individual based on their health. So again, when we're trying to define it for the general public, those are some general standards. That's why we encourage folks to see you or myself so that we can actually truly define what is your risk for heart disease and stroke. Is your BMI really elevated? Or you have a high BMI, but you're actually very physically fit with low body fat. And so it's hard to measure those things clinically in a real setting. But for someone that's really concerned, has the money to invest in those things, they can get DEXA scans and different things to measure their actual body fat percentage. But again, the BMI is a rough way to estimate your risk factor for heart disease and stroke and say whether you're overweight or obese.
And the trend is even more important. So if you start some sort of a workout plan or a diet plan, if you measure your BMI over time, the fitter you get or the less obese you get, it should show up in your BMI as a trend, right?
Yeah, you can see that. So it's a way that as a physician, I can measure that in my office and say, hey, you came in 6 months ago and your BMI was 30. You've been exercising, your blood pressure has gone down, your blood sugar is better, your cholesterol is reduced, your BMI is now 28. Doesn't seem like a significant change, but you've improved a lot of the quality measures that we look at. And so that person is doing better with their health when they improve those things. So it's not just that BMI, it's the collective person that we're looking at.
Okay. That's good to know because, like you had mentioned, the World Health Organization, they determine BMI around that 25 number. And then if you go higher than that, that's when you kind of are in trouble. But there's a lot of different factors that really indicate your health. And so, tying that in to cardiovascular care, why is it so important for just that, you know, the average person to need to think about that concern of being overweight or obese with their cardiovascular care?
So what we're seeing, unfortunately, and Dr. Keller can attest to this, Sabrina, I have children that are on the same medications as their parents. And used to hear about, when you're a pediatrician and then an internist tries to take over a pediatrician, they're just little adults. Well, that's not true. But with obesity, it kind of seems to be true. An obese child typically becomes an obese adult, especially if we're not modifying those risk factors or behaviors that they may be learning about how they eat, access to care, exercise, the diet, as Dr. Keller mentioned earlier. So obesity is a major risk factor for many things, as you know, cancers, hypertension, liver, gallbladder disease, sleep apnea, arthritis. And so it's associated with so many other diseases. Reducing or preventing that from happening to someone is improving not only just their quality of life, but their lifespan. And so as a physician, that's one of my goals, is to really stress health, being healthy, and not just healthy, but being well, managing all those factors along with your mental health and other things that we can get to later. But when it comes to specifically to diabetes and obesity and asthma and heart disease, all those things are interrelated. So if you're knocking obesity out, Doc, and I mean to cut you off, you knock obesity out, you're improving your potential to live longer just based on that alone.
So tell me about the mechanics of that. How does obesity impact your cardiovascular health from a mechanical standpoint?
Let's start with arthritis or at least joint health. A heavy person is putting more weight bearing on their spine, hips, knees, and ankles. And so we think that extra weight that's being carried around puts more stress on the joints. And so those folks potentially are at increased risk of arthritis. they talk about central adipose or central obesity or adipose tissue around the stomach. If you have that big pot belly stomach that someone talks about, that beer belly that folks talk about, that same amount of fat could surround the heart, constricting the heart and decreasing the heart function. And so mechanically, yes, that's what we think is happening. But I think the bigger picture is, how does that happen to a person? Some folks are born like that. It's not always the thyroid. In my African American community, a lot of folks say, "Oh, that thyroid is probably
it's my gland. It's my gland."
Doc, I can't tell you how many times I've checked the thyroid, and that has not been a problem, but it's been more than less. And so you have multiple layers to this scenario. I think the biggest thing that I stress to my patients is getting in and getting checked, knowing the family history, and taking the medications prescribed. If we can control, Doc, I'll admit this to our family on the show. I am taking medicines for high cholesterol. You know, my cholesterol has been up for some years. We have a strong family history of high cholesterol. I've done everything. I've exercised. My diet could be a little better. I do eat some red meat. But because of that history and some history of heart disease, I've been on high cholesterol medicines, hoping to reduce my risk of having a heart attack or stroke.
So being obese or overweight really actually does put strain on your heart as well, though. It takes a lot more cardiac function to be able to maintain the metabolic demands of your body.
Correct.
And so if you are 100 pounds overweight, your heart has to work that much harder to be able to allow you to be able to function.
That's
and
correct.
It can, over time, increase your risk of high blood pressure and increase your risk of dyslipidemia, which is high cholesterol, which are two of the main accelerators of cardiovascular disease that we know about.
Correct. Throw in some smoking, and some Louisiana soul food, and you got a ticking time bomb. So it's been our mission and the mission of most of the doctors that I work with, to educate and prevent. You know, we practice kind of behind the 8 ball, and I joke Sabrina all the time and say, when I'm calling Dr. Keller about you, it's a problem. But truthfully, that is an issue when it's dealing with someone who had a preventable issue but has ignored instructions from taking the medications prescribed, seeing the endocrinologist, primary care doctors. When by the time I get them to Dr. Keller, it's usually pretty serious. And that's that heart disease patient that could have prevented years before they presented to him. But some folks just don't take it seriously, because in many cases, heart disease doesn't hurt until it hurts you. You know, so heart attack or stroke, you don't hurt until you have, why am I having chest pain? At rest, something's going on. And so then they come and I send them to the cardiologist, and some end up in Dr. Keller's operating room, which is not the place we want to be.
Right. Following up on those statements that you were making about some people and their family history and associating that with their own health. So there's kind of like this myth, I guess, that relatives think that because they resemble their family members, that they will also end up with the same health outcomes.
Right.
So just to clarify for our community, is obesity something that's genetic, or are there certain chromosomes that have to do with that, or is it behavioral?
So Doc, you know, sometimes I tell my patients, they come to me and they say diabetes runs in my family. And I say, no, it's because nobody runs in your family that everybody has diabetes.
That's right.
So I should stop telling them that, or is that partially true?
No, I think it's partly true. Behavior, environment, genetic factors, they all have a role in causing people to be overweight or obese. So yeah, I mean, we know there's been that what calories in, calories out, obesity results from the energy imbalance. But there's multiple factors, and I think one of those factors is what we talked about a little bit, or mentioned a little bit earlier, Sabrina, was the food deserts and access to healthcare, healthy plus shared use agreements, so you can go out and use parks and football fields to exercise. Many of my patients don't have these resources. It's colder right now, folks in Louisiana, and so they don't want to exercise. I battle it all the time. You come to my house, I have a tonal exercise machine and a Peloton bike, but some folks can't afford to do those things. They don't have access to the gym. You can tell somebody to walk in place to their house where they're watching TV, but how many people really inspired to do that? They've had an event.
You know, I have a special place in my heart for healthcare disparities and promoting health equity. And I want to go back to the food desert issue for a moment because I think it's a really important issue for people to understand, especially people who have not grown up in disadvantaged communities or in communities where they don't have a grocery store, for instance, within 5 miles of where their house is, or people who find it much less expensive to eat junk food or processed food as opposed to fresh fruits and vegetables because the fresh fruits and vegetables cost so much now. This is a big problem, and it is a problem that I don't think some people appreciate because of the fact that in the richest country in America, we have so much access to these things in certain neighborhoods or in certain places. There are places, even in Baton Rouge, where you have to travel 5 or 6 or 7 miles to go to a grocery store.
Correct.
And if you don't have transportation, that becomes an issue.
Another
If
issue.
you don't have a car, if you have to take public transportation, or if it's not safe to go to a safe place to be able to do your shopping or to exercise, these are real problems that real people deal with every day. And I don't think we pay enough attention to the fact that these situations exist in people's lives. Not that it's an excuse for them not to eat healthy, but it is something structural that we need to try to see if we can have an impact on in order to be able to make our population healthier as a whole.
Without a doubt, Doc, from school-based programming, some of those children's meals,
Mm-hmm, mm-hmm.
better meals, come from them going to school. So
Right.
when school's not in, or you got parents, two-parent household, but both parents are working late, fast food is easy. A bucket of chicken, a gallon of sweet tea,
Mm-hmm.
some coleslaw, and some biscuits will go a long way in a family that
Right.
can afford to grill chicken and salmon and that type of thing. So it's a very, very real issue. Transportation, you spoke about, that's also key, as well as safety issues. Traveling around is very dangerous in some parts of town. So if you don't have if you decide to walk to the grocery store and don't have the sidewalks to get there, the bicycle to ride, and you're walking in dangerous territory,
Mm-hmm.
a whole nother level of risk. So many layers to this to consider. But as you mentioned and you asked earlier, what are the factors leading to this? It's multiple things: behavioral, genetic,
Yeah.
environmental. You talk about social
Mm-hmm.
determinants of health; they are very, very important
Right.
to the survival of our community.
Yeah, food insecurity is a really big issue, and I did not want to let this session slide without mentioning it because it has a significant impact on obesity and wellness.
Some of my patients, again, not to cut you off, they do their shopping at these local corner stores that have,
Mm-hmm.
the sugar sweetened beverages, no fruits and vegetables. They may have some older bananas and some fruit, but they're usually
Mm-hmm.
not quality. So they're buying lots of
Well,
chips,
I,
dips, and
I went in one of those stores and it was $3 for a banana.
yeah, very high. Even
Oh my
even in that
goodness.
environment, it's still high. So yeah,
Mm-hmm.
we have a huge problem in our country to face, and it's interesting that the emphasis is not placed more on the prevention side of things when you got guys like you having to do surgery on folks, and it's like even after that, some of those folks are still not able to afford the care that they need to maintain their living. So it's a
Mm-hmm. Mm-hmm.
tough, very tough situation.
That's right.
Yes. Yes, it is. And I mean, it's even gotten more increasingly drastic for our communities after the pandemic because
Yeah.
now people have to figure out the money they had to save during the pandemic while they weren't working, they have to use towards feeding their families. And then that also takes into consideration the transportation. Well, do I pay for transportation and a full day to go see a doctor and think about my health? Or do I focus on taking care of my family? So that
Yes.
is a
Yes.
lot to consider. And that kind of a statistic to follow up on that is that non-Hispanic Blacks, it's
Mhm.
21.7% that it was in 2020 that food insecurity was prevalent. And also for Hispanics, it was 17.2% of households
Yeah.
compared to the national average of 10.5%. So
Mm-hmm.
that
The numbers are
even
real.
furthers those numbers in that situation.
We live a very privileged lifestyle, Doc, and I didn't really appreciate it as much until the pandemic because I was working from home. I had paid time
Mm-hmm.
off. There still had the individuals in our community who had to go to work and didn't have sick leave, didn't have paid time off. And those folks, you see, how do you survive in an environment? You got to go to work, and then you're cutting pennies to feed yourself. So you end up buying those cheaper foods and calorie dense foods with no nutritional value to them to sustain themselves, and it's just survival. And it's tough. It's a tough lifestyle. So you realize how privileged you are when you try to tell somebody to eat healthy and exercise. I'm blessed to have a social worker in the office who can say, well, why is this person's blood pressure still out of control? Why is their diabetes out of control? Why aren't they losing their weight? And when she goes and talks to them, but they don't have transportation. They don't have money to make their copay. That's why they didn't follow up in 3 months. So those are things that come out of the conversation when you have someone that can have that real. And Doc, we're pressed for time. They want us to see 30, 40 patients a day. And you just can't do that type of medicine and really help folks if you can't get the full story.
Let's talk about stress and obesity. And I think that's mental health is an issue that has been getting a lot of publicity lately. But I think that people are looking for real solutions to reduce the amount of stress, because stress is a surrogate for overeating. There are a lot of things that you do, bad habits that people have that they blame on stress: overeating, smoking, anger management issues. Stress is responsible for all of those. So it seems to me that one of the most important things for us as physicians, especially as primary care physicians, would be to check on people and see if you can help with their mental health and their stress reduction. And that's why I applaud you for having a social worker in your office who can focus on these kinds of issues. Clinical psychologists in primary care offices are actually something that is relatively new, I think, but it's having a significant impact on the population in general and their well-being.
A part of my day-to-day, Doc, is a social determinants health question set that I use, and I ask those questions to patients every visit. And some doctors are intimidated by that or don't feel like they have the time to do that. But it's for me, does several things. Gets me in the conversation so I get to know the patient. Then I can follow up on a secondary visit and address the 1 or 2 areas that may have been troubled, like resources, access to healthcare, finances, food, whatever, food insecurity, whatever it may be. But it builds rapport and a relationship with the patient, and then to have the social worker follow up and be able to address some of those issues and help the patient navigate is a blessing. So you're correct. Having clinical social workers and mental health professionals available and accessible to your patients are cool. I'm on the board of supervisors at the greatest HBCU in the world, which is Southern University. And we're now debating mental health days for our students. We've had a couple of suicides in the last couple of years. So stress is real. Let's get to the metabolic aspects of it. You got cortisol that increases, which can increase your blood sugar, increase your blood pressure, and increase your weight. So we think that stress cortisol has a lot to do with some comorbidities that we see, at least in our patients that either have pre-existing disease or may predispose them to those diseases. So again, family history may start with someone, but you may have those disorders, and they're exacerbated by your stress levels. And you're totally right. We need to do more in addressing those from primary care and specialty perspectives.
Wow. And like Dr. Keller said, Dr. Whitfield, your patients are so fortunate to have that social worker and that cultural nuance within your clinical setting to feel comfortable enough to talk to you about how they're feeling with their different health issues that they may have and addressing those. But I mean, what about those other people that are experiencing that weight stigma with their doctors, for the ones that are, go through their patients? Can you speak to that?
Yeah, I mean, there are harmful weight-based stereotypes. It's tough. Some folks that are physically fit and maybe even using other things to enhance themselves that aren't legal will judge people. And you see, there's a guy on YouTube that goes off on folks that criticize people in gyms for being overweight who are trying to lose weight. But it's a hard stigma, and it's actually, in my opinion, a form of discrimination towards obese people. Very pervasive to judge folks based on their weight, because you really don't know what's going on. And so it's tough, from airlines and sitting on planes to just being laughed at in public. because you're overweight or obese. It's a tough lifestyle. I had a conversation with a patient the other day that said they're just embarrassed to leave their home because they're so overweight, but they really are trying. They're doing everything that I prescribed them to do. And now we're at the point, Doc, of bariatric surgery is going to be kind of the last result. But they've done everything that I've asked them to do, from diarying, jogging, journaling, the whole nine, and it just cannot lose the weight. Um,
And
and they
so,
are
you know, our good friend, I'm sorry, go ahead.
Oh no, finish that, Doc. Finish that. I was just kind of
Our
rambling.
good friend Jonathan Taylor, who's one of the best bariatric surgeons I've ever met,
Right.
is shown some remarkable results with laparoscopic or robotic bariatric surgery and weight loss. That is really impressive. And lately, you know, we've been hearing a lot about these medications that you can take as an injection once a week or once a month to be able to control your weight. And I would like for you to expound upon those medicines, and if you think they are valuable for this fight, and if you think there are some things that people need to look out for or worry about with these medications as well, because they can have such a profound impact on obesity.
Right. There are 5 drugs out that people really ask for or know about: Mounjaro, Ozempic, Saxenda, Trulicity, Wegovy. Semaglutide is the drug, and those drugs are different variants of the same. One oral medication called Rybelsus also, but those drugs are supposed to be managed or used in diabetics. Well, as a side effect of the use of that medication, we've seen some significant weight loss in individuals. It varies per patient, but I've had a couple patients, Sabrina, Dr. Keller, that have lost 30 to 40 pounds in 4 or 5 months on a once a week injection that is very painless, easy to use, but it's now almost, you can't find it. It's unavailable. You have individuals in my office who are struggling to lose weight, or just that subset of folks who haven't put the effort in and want the quick way to lose weight, to say I have diabetes, or want me to create notes for them so that they can look diabetic so they can get the medication. We now have a shortage of it, and my patients who truly need it, my diabetics who truly need it, can't get it. But the drug seems to be legitimate for controlling diabetes. And again, the side effect of weight loss may possibly become an indication. I'm sure they're researching that to see if they can become an indication for weight loss. There's some plastic surgeons in the country that use it for weight loss. It's not indicated for weight loss. It's indicated to treat diabetes, but some folks are using it. So we call it off-label use, Sabrina, when someone uses a medication to treat something that is not meant to treat. And so the doctor takes some risk in doing that. But for a diabetic who's using one of those injectable medications, or even the Rybelsus, the oral medication, to try to lose weight, it's not just about weight loss. It's about managing that diabetes as well. If you reduce weight, the sugar comes down as well. So, you know, from whatever your issue may be, but that drug does seem to be pretty effective, Dr. Keller. I don't know what you've seen.
Well, I haven't dealt with it as much because of the fact that I'm downstream. So it's going to take a little while for me to be able to see people who have been on these medications. But are there situations in which you think people should not take one of these medications?
Yeah, there's some potential
contraindications
to the medication. And I just encourage everyone to meet with their physicians to discuss what's best for them. What's frustrating for me, though, is the folks that come in lying about being a diabetic. They know what to do. They'll have an elevated blood sugar when they come in. But as a physician, I have to manage the quality of that patient. So you need a diabetic foot exam, diabetic eye exam, you know, certain lab tests I need to draw on your hemoglobin A1C, microalbumin. They don't want to do that. They just want the medicine to lose weight. And that patient probably won't be successful, because once they're no longer taking the medication, they're going to gain the weight back because they have not changed their life.
So that was my next question. How long does it last? And really, I think that one of the most interesting things about it is it causes you to pay attention to what you're eating and what you're not eating. And that hopefully leads to some behavior modification and a lifestyle change. And if it doesn't, then you will relapse.
Yeah, you're wasting your time. Suppress the appetite significantly, can cause some GI issues, nausea, upset stomach. But you also saw that with metformin, which was they claimed to be the wonder weight loss drug. I did not see the significant weight loss with metformin like I'm seeing with the semaglutides and like I said, the 5 drugs. Yeah, I'm seeing some pretty impressive weight loss. I mean, to the point where one lady's like, I got to stop. She's just like, this is too much.
Mm-hmm.
Like I mentioned, that patient I talked about that struggled with the weight loss, she is being seen by Dr. Jonathan Taylor, the great Dr. Jonathan Taylor. And so he'll be taking good care of her. But again, that bariatric surgery is usually that salvage procedure that's saved for that last ditch person that we just can't get it right. We've done everything we can do from a medical standpoint. They've done everything they're supposed to do, and it's just not coming off. And so to put the stigma on someone because they're obese, Sabrina, is very unfair, because there's some folks that just struggle with the weight loss for multiple reasons. And again, we talked about behavioral, environmental, multiple layers to that. And so getting back to your original question, is the stigma discrimination is unfair and unwarranted. There are some folks who have made bad choices, bad decisions, but in many cases, I see there's a lot of layers to that as well.
Mm-hmm. Yes. I also find it really interesting that you were able to speak about the different medications that people are taking, and that some people are kind of cheating their way into getting this type of medication and treatment. But are they also seeing any kind of negative effects, or is that kind of speaking to the fact that there aren't enough studies out there?
Just probably not enough studies. The folks that I know that have done it, that did not have diabetes and lost weight, only thing they may have complained about was just the loss of appetite. No hypoglycemia. That's not a drug that's in the category of causing hypoglycemia. The biggest thing has been the GI upset, nausea, indigestion in some folks, but not much. So again, there's not a long-term studies to say what that may do to insulin sensitivity in the pancreas down the line. But I guess the jury will be out. We'll see. But that would not be my way of treating someone without diabetes. I would not use those drugs in that patient unless there becomes an indication for that down the line. I would wait. I would hold off.
Mm-hmm.
Right.
So let's talk about exercise and obesity. And since Sabrina brought up a very good point about, quote, fat shaming of people who are trying to do their best to lose weight. And I think one of the most interesting things to me is how people know that exercise is going to improve your weight, it's going to improve your mood, it's going to improve everything about your life. But not everybody knows how to go about starting an exercise program, and where can they go to learn how to safely start an exercise program. And if there's one piece of technology that you think would be the most useful for someone who's trying to start an exercise program, what would that be?
So let's start the first. Who would they see first? They see me. You see a primary care doctor, and make sure that you can exercise. If there's no functional limitation, you don't have jacked up knees and ankles, and you can move and you can walk. The first exercise that I recommend to most people is something that they love to do or like to do. The biggest excuse for exercise or lack thereof is time. And so, doctor, I'm not bragging, but you see my videos. I post them at 4 or 5 in the morning. I have a son that's
getting
playing. Yeah, I got to get it, but that's my time. That's the time to get it. And it's an appointment for me. It's that serious to me. I love to exercise, and it's important to me. Some folks don't like to exercise, so you have to stress to them the importance and the benefits of exercise, from cardiovascular benefits, bone health, mood, energy, sex drive. It can improve all of that if done in an appropriate way. But the first person you would see is me. And the exercise that I usually recommend to most people that just haven't done it before, don't understand it, is walking. It's not expensive. You can do it anywhere. My wife and I had a step challenge one year, and when it would rain or be cold outside, we would watch, what's the show, Sabrina, with Olivia Pope? What was it called? But anyway, she would be in bed, and I would stand by the bed and walk in place while we watched this TV show together and get my steps in. That's how competitive I am, Doc. I'm surprised I'm still married because of that.
I believe it. But, that's only because she beats you all the time, and that's
Scandal. There you go. Scandal. That's it.
Scandal. That's it. Yeah.
All right.
That's our little bonding time.
I love it, and I think that pedometers and heart rate monitors are very cheap right now.
If
you can get one for just a few dollars, and I think it can make a big difference. And one of the things I think that it's important for people to know is, people can walk and say, well, I walk a mile every day. And if it takes you 30 minutes to walk a mile, that's not going to do very much for your cardiovascular health.
Not at all.
So we usually try to tell people that they have to get their heart rate up to about 75% of what their maximum heart rate would be. And so we're
Easy.
going to give another fact today. How do you calculate that? What's the easy way to figure out how fast your heart should go before you are deriving some cardiovascular benefit from your exercise?
Very easy formula, 220 minus your age, and then you multiply that times 75%, 50%, 60%, whatever the percentage is that you want. But if you're saying 75%, we would take 220 minus age times 75%, and that's your max heart rate. So that's what you should be trying to achieve.
Okay,
And,
so for a 20-year-old person, that would be 140 beats per minute would be what you're trying to achieve. For a 40-year-old person, that would be less than that. So 220 minus 40 would be 180, and then 70% of that would be about 135, 134, somewhere around there.
correct.
Okay, so somewhere more than 120 beats a minute for most people.
That's right.
But certainly less than 140 beats per minute. We have to make it easy so people can kind of understand the range we're looking for.
But
And
again,
so
you said who you start with. If you come to your primary care doctor, we can help figure that out. So I always tell folks, you got to see your doctor. Again, being in the privileged mindset that everybody can afford the doctor, has insurance to see the doctor, can go. But those that can, you have no excuse for not asking that question to figure out how to achieve that heart rate and what you can do to get there.
yeah, and one of the most interesting studies that's come out in the last few years had to do with how much exercise and how much dietary modification it takes to be able to have an impact on your cardiovascular health. And the American Heart Association, it's been a moving target about how often they expect you to exercise. They started off 3 times a week and then went to 5 times a week. Now it's every day for at least 30 minutes in that target zone, and 60 minutes for weight control. And that's the most important thing for people who are over 30 years of age. You need a combination of diet and exercise, but if you want weight control, you have to do it for a little bit longer every day.
That's it. And so, but it can be cumulative. You don't have to do it all in one setting, 30 minutes in the evening, 30 minutes in the morning. So you got to keep those things in mind too. There's really no excuse, but people find that excuse all the time. And I think both of you and I agree that prevention is key. And if you're doing these things on the front end, you're going to avoid more points with Dr. Keller and Dr. Whitfield to manage blood pressure, cholesterol, heart disease. And that's my ultimate goal, Doc. I always joke about, you guys, you and Dr. Green sending folks to y'all, but I'd rather send a healthy person to you just for screening because they had a family history of heart disease than say, Doc, I think this guy's going to have a heart attack or stroke. Go on and work him up and get him to Keller because he's going to surgery in a couple of weeks. And unfortunately, Sabrina, I've had to do that more than I would have liked to admit to.
Well, I feel like this has been a very enlightening conversation for myself, and I'm sure for the community that's going to be watching this episode. And I mean, we were able to cover facts about obesity, about heart health, how that all ties in, but then also really delved into the concerns with food insecurities and weight stigma, and then also still got back to the idea of exercising and was consistent with what Dr. Lamott said in our previous episode. So thank you so much, Dr. Whitfield and Dr. Keller, for your time today. And I look forward to hearing what our viewers have to say about this episode.